Good evening, everybody. Welcome to the latest installment of CAEP's National Grand Rounds. My name is Andrew McRae. I'm an emergency physician and researcher based at the University of Calgary, and I'll be moderating this evening's session that showcases Canadian research that gives evidence that can guide our care of elderly patients. Canadian emergency research is often talked about as being the best in the world, and I think this is especially true for Canadian research in geriatric emergency medicine. Today's presenters are among the top Canadian EM researchers whose work focuses on the care of elderly patients. Each presentation is going to be 9 minutes long, followed by 20 minutes of live Q&A with our presenters. If you have a question for one of our presenters, please type it into the chat, and we'll try to get through as many possible questions at the end of the session. Our first presenter is Dr. Geriatric Graywall. She's an emergency physician at Mount Sinai Hospital, a clinician scientist at the Schwartz-Reisman Emergency Medicine Institute, and an assistant professor at the University of Toronto. Geriat's a health services researcher whose interests include the care of patients with cancer in the emergency department and issues surrounding anticoagulation and venous thromboembolism. Our second presenter is Dr. Marcel Lemont, who's an emergency physician and trauma team leader at the CHU de Québec Enfant Jésus Hospital Level 1 Trauma Center. He's an associate professor and clinician scientist at Université Laval. His research interests are trauma and geriatric care in the emergency department. He's also the conference chair of the CAEP Conference 2022 in Quebec City this summer, and I'm sure he'll be talking with you about that. Our third presenter is Dr. Deborah Eagles, an associate professor in the Department of Emergency Medicine and the School of Epidemiology and Public Health at the University of Ottawa. She's an associate scientist with the Ottawa Hospital Research Institute and an emergency physician at the Ottawa Hospital. She holds a junior clinical research chair in geriatric emergency medicine at the University of Ottawa, and her research focuses on improving the care and outcomes of older people presenting to the ED. She has a special interest in altered mental status, frailty, and geriatric trauma. Our final presenter of the evening is Dr. Jacques Lee, an emergency physician and the inaugural research chair in geriatric emergency medicine at the Schwartz-Reisman Emergency Medicine Institute in Toronto. His research is focused on geriatric emergency medicine as a means to improve the care of older people who use the emergency department. He's focused on delirium, which is the focus of his research using technology, including gait trackers and serious games to recognize and prevent delirium in the emergency department. He was recently awarded a 5-year operating grant to lead a team of clinicians and researchers to investigate the use of urine metabolomics to understand underlying mechanisms leading to delirium. In response to COVID-19, Dr. Lee was recently funded to develop a program of research to understand and improve the impact of physical distancing on social isolation and loneliness in vulnerable older ED patients. CAEP's Scientific Planning Committee has reviewed each presenter's conflict of interest submissions, and the following potential COIs have been identified. I receive research funds from the Canadian Institutes of Health Research and Roche Diagnostics, and I've consulted for Servier Pharmaceuticals. No external support has been received for this webinar, and none of the other presenters had any relevant conflicts of interest. Before we get going, I wanted to highlight the importance of CAEP's Emergency Medicine Advancement Fund. This fundraising initiative supports research grants for trainees and docs in the first few years of their career, and it has helped kickstart the careers of researchers like Jeff Perry, Christian Vaillancourt, Catherine Varner, and others, and ensures that the next generation of Canadian researchers can develop practice-changing evidence. You can donate through the CAEP web portal the same way you renew your membership, and it's tax deductible, so I encourage you to donate if you see value in Canadian EM research, and I hope that you do. So let's get going. This is going to be a fantastic hour of learning, so let's get started. Dr. Graywall, please take it away.
Hi everyone, my name is Geriatric Graywall and I am an emergency physician at Mount Sinai Hospital in Toronto. And today I have the opportunity to discuss head injuries in elderly patients with everyone. And I'll be reviewing some of the evidence and focusing on some of the Canadian evidence in this field. I don't have any conflicts of interest to declare. However, one of the studies of mine that I'll be discussing did receive funding from CAEP in terms of a CAEP EMAF grant. So the objectives of my part of the talk today will be to review the risk of intracranial hemorrhage, or ICH, among older patients with a head injury that we see in the ED. Second, I'll discuss the role of imaging in older patients with a head injury or fall. And then finally, I'll review some of the newer evidence that I've been looking at anticoagulation and head injuries in older patients. To give you a bit of a background, we know that falls and head injuries are common among older adults, and we often see these patients in the ED. We also know that older age is associated with an increased risk of intracranial hemorrhage after a head injury. And a majority of these head injuries that result in ICH are actually from ground level falls. Now, it's thought that older patients are more susceptible to bleeding after a head injury because of brain atrophy and a loss of elasticity in the bridging vessels that make these vessels more susceptible to rupture after blunt trauma. There's quite significant morbidity and mortality associated with traumatic intracranial hemorrhage. So it's important for us as emerge physicians to be able to identify those at risk, the risk of bleeding after a head injury, and actually identify the bleeds as well. Now, many elderly patients that we see in the ED with a head injury undergo head imaging to rule out intracranial hemorrhage. And this is because a lot of the clinical decision rules that we use in the emerge often have older age as a predictor of clinically important brain injury on imaging. And so one of the most common clinical decision rules we use in the emerge is probably the Canadian CT head rule by Dr. Ian Steele and all out of Ottawa. And just as a refresher of the rule, one of the high risk criteria for brain injury requiring neurologic intervention is age over 65. Now, it's important to remember what the inclusion criteria for the Canadian CT head rule are. And so those include GCS of 13 to 15 in the ED, an injury within the last 24 hours, and the patient must have had one of either a loss of consciousness, amnesia, or disorientation. So if your patient meets the inclusion criteria and is over the age of 65, these patients are often getting a CT scan of their head to rule out bleed because of the increased risk of bleeding. Now, if we wanted to know how much higher the risk is in the older age population, we can look at the derivation data from the Canadian CT head rule. And so this is from the derivation study of the CT head rule. And as you can see, in this study, they had over 300 patients, so 356 patients over the age of 65, and 75 of them had a brain injury on imaging, so an incidence of over 21%. And this was over 3 times that in the younger population. And this higher incidence of brain injury in older patients is seen in other clinical decision rules like the Nexus CT head rules and also the New Orleans criteria. Now, what about patients who fall? So oftentimes the older patient will come into the emerge and we know that they've had a fall, but it's unclear whether they hit their head. And this is either because the patient doesn't remember the fall or there's an element of confusion, delirium, or dementia. So it's unclear if they actually hit their head. There have been several studies that have looked at which patients are at increased risk of intracranial bleeding after a fall. And one of the Canadian studies that recently looked at this was led by Dr. Kirsten DeWitt and all out of Queen's University. And they did a prospective study looking at clinical predictors of intracranial bleeding in older patients who have fallen. And in this study, they had over 1,700 patients, and the incidence of intracranial hemorrhage was about 5%. And when they looked at what predicts intracranial bleeding in these patients, it was things that you can easily pick up on history and physical exam. So new abnormality on neurologic exam, a head laceration or bruise, chronic kidney disease, and a reduced GCS. Now, the other question with head injuries is often, what about patients who are on anticoagulants? So the older patients are more often likely to be on different anticoagulants for various clinical indications. However, we really don't know how they kind of fit into the clinical decision rules because patients on anticoagulation were excluded from most of the decision rules, including the Canadian CT head rule. And in the newer era of DOACs, where DOACs are kind of being more prescribed than warfarin, we don't have a lot of real world data comparing the risk of intracranial hemorrhage between anticoagulants after a head injury. So our group recently published this study, which was published in the CMAJ last year, and it was a population-based study using administrative databases from Ontario. And what we did is we looked at patients over the age of 65 who presented to any Ontario ED with a triage complaint of a head injury. We then looked to see who was anticoagulated and then looked to see who had a diagnosis of an intracranial hemorrhage on that emergency department visit. And so as you can see, we had over 77,000 patients with a head injury over the 3-year period. And if we look at the incidence of intracranial hemorrhage, you can see that the incidence of intracranial hemorrhage in the entire cohort was about 5.9%. If you look at those who are not anticoagulated and those who are anticoagulated with a DOAC, the incidence of ICH was 5.8 and 5.9% respectively. However, when you look at those on warfarin, there is a higher incidence of intracranial hemorrhage at 8.2%. Now, we want to compare the risk of intracranial hemorrhage between these three cohorts, but we know that patients on warfarin are often sicker and frailer than those on DOACs. That's because DOACs have many contraindications to them. So if a patient can't have a DOAC, they're often put on warfarin or a heparin. Now, we also know that patients who are anticoagulated with either warfarin or DOAC are probably different from those who are not anticoagulated. So when we compared these cohorts, we wanted to try and make these cohorts as similar to each other as possible at baseline. So we used propensity score matching to match each of these three cohorts to each other based on various demographic factors and comorbidities. And so after our propensity score matching, we compared the risk of intracranial hemorrhage between cohorts, and we actually found that when you compared patients on warfarin to a DOAC, patients on warfarin were more likely to have an intracranial hemorrhage. Similarly, when you compared patients on warfarin to no oral anticoagulation, patients on warfarin were also more likely to have intracranial hemorrhage compared to those not anticoagulated. And finally, when we compared DOACs to not being anticoagulated, there is interestingly no significant difference in the risk of intracranial hemorrhage. So this data suggests that warfarin patients may be the only group of patients that are actually at an increased risk of intracranial hemorrhage after a head injury. Now, before we start to use this in the emerge on a daily basis, we do need to prospectively validate these results and also validate these results in other populations. So stay tuned for the CAN-SCAN study, which Kristen DeWitt is leading at Queen's, which will be a Canadian study across Canada looking at the risk of bleeding in head injured patients who are on anticoagulants. Now, going back to the cohort that I just described, we also wanted to look within DOACs and look at the risk of bleeding between DOACs, because we know the different DOACs have different mechanisms of action. And interestingly, we found that none of the DOACs had a significantly increased risk of bleeding compared to another DOAC. Now, I just want to touch a little bit on delayed bleeds, because this is often a concern among anticoagulated patients, and this can occur days to weeks after a head injury, and it's thought to be increased in there's thought to be an increased risk in patients who are anticoagulated, with an incidence quoted anywhere from 0.2 to 6%. Now, some protocols, mostly outside of Canada, so more so in the US and Europe, suggest in-hospital observation and repeat CT scanning for these patients in 24 to 48 hours. I'd say that most hospitals or emerges across Canada don't currently do this, possibly because of the low incidence of this. In the same cohort of patients that I described, we are looking at delayed bleeds and working on that data right now, but it seems as though the incidence is quite low at 0.7 to 0.9%. So I just want to finish off with some concluding thoughts. So older patients who fall, we know, are at increased risk of intracranial bleeding, and many of these patients will receive imaging in the emergency department. But it's important to remember the inclusion criteria of the decision rule that you're using and apply those appropriately. We have some new data that is showing that warfarin may have an increased risk of bleeding compared to DOACs after a head injury. However, we do need some future studies in order to determine whether warfarin users are the only group at higher risk of traumatic injury. And that's all for me. I'm going to now pass it on to Dr. Marcel Aymond.
Thank you, Dr. Gorel. Just to follow up on your delayed intracranial hemorrhage, we've been doing research here also in Quebec and show that it's very, very unusual, so lower than 1% in cohorts we have here on anticoagulation. So it's probably not worth it to have all those patients admitted to the hospital. So before I start, I want to invite all of the participants to this Grand Rounds to attend this summer annual CAEP meeting, who's going to be live in person, we hope so, in Quebec City. So I'll be hosting as a local chair with Catherine Patoka as the national chair of the next annual CAEP conference. So moving on, we're moving to the evaluation of medical cause of traumatic injuries in older patients, mostly fall, obviously. So very quickly, a lot of older people do have a fall during a year, about 40% of patients living in community, 50% of nursing home residents have a fall. Falls is #1 reason for injury. related to death and hospitalization and emergency department visit. Falls is costing a lot, nearly 20% total cost of injury in Canada. So what about the causes of fall? Dr. Gural talked about, scanning the patient, and we'll touch very quickly on the scanning the patient also later on in this presentation. So interestingly, the causes of falls, we're often looking for a specific cause, but olders usually have multiple causes for falling, not only one reason. So the historical teaching were that we use the intrinsic factor, which is age-related decline in function, disorder, adverse drug effect. Extrinsic factor basically are any hazard environment of the patient, and also some situational factors where the patient need to go quickly to the bathroom, example. A very simple mnemonic I used to teach, and I still use with our resident and our medical student, is that catastrophe is a quick mnemonic to make sure that you're looking over the reason of fall. If you go over this mnemonic, actually, you see that caregiver alcohol intake or alcohol abuse, treatment as medication, depression, syncope, dizziness, recent illness, ocular problem, pain with mobility, hearing, any environmental hazards. This is not the usual stuff we've been told many years ago in emergency medicine. Sometimes we're quite puzzled as emergency physician to try to find one reason for a disease. So the first EBM teaching point is that you have to start with a complete history and physical. There is no data on this, but for the reason we have for the cause of fall, we need to make sure that we do a complete history and physical on most of those patients to really orient what we're going to do for investigation of the cause of fall. So sometimes as an emergency physician, over the last 20 years, I find myself on a balance here of having an older senior patient in my emergency department that have a fall, and they don't look too bad, and whether or not I should investigate. Obviously, they have multiple reasons for falling in their charts, and as emergency physician, usually we used to do a lot of very quick time pressure time pressure care, and also we'd like to look for one possible cause for a disease, and we don't really think about multiple causes. So with all this in mind, at the balancing part, over the last couple of years, we found in practice that sometimes we're drifting to do more tests on those patients that come in with a fall or a simple fall than need be. So this is a kind of an unpublished retrospective study we did with a summer student here in Quebec, where we used 3 university-affiliated emergency departments. We used 3 patients. They were random sample, and they were collected data on them. So we had patients 65 up, look at simple fall, only 5% reported syncope. Head injury was reported, maybe not noticed in the chart, in 45%. And if you look at the right side of your screen, you see what kind of investigation they had. Heart monitor in 17%, complete blood count, and regular bio was 68%, and 2/3 had anemia. Troponin was done in about 58%. 1/6 were positive as for the troponin level, but only 1 really had the kind of an acute cardiovascular event. EKG was also done in 62%. 7 out of 10 were not considered normal. Head CD was 58% had a head CD, and only 1 out of 20 patients had new acute findings. So with that in mind, it did question our team, or what do we do, especially for heart investigation? As emergency physician, we want to make sure we're not missing anything, especially in MI or a non-STEMI. So what we did is that to assess this is a systematic review that's unpublished and submitted right now and been presented in some meetings. Basically, we went over about 500 records. We try to select the articles where they had a simple fall and they were in the ED and they were non-syncopal fall, basically, and see what was the advantage of the troponin. So 2 we found only two study at the end. Sorry, I changed my slide a bit quick there. Only two study at the end that we used, and those study were looking at, the study of the results were, the results of the study were the following. One study from Australian Emergency Department cohort showed that about 17% of the patient with a suspected and non-STEMI had basically positive troponin. And we had a similar percentage basically of patient without a suspected event or cardiac event that had a positive troponin. So if you do troponin, there's a high likelihood ratio, that a likelihood risk actually that you're going to find a positive or false positive. Similarly, what we had was, switch one. Another article actually that was found in this systematic review and dated from 2010 was a French study looking at all patients with a fall, had no idea, that had no suspected cardiac event, and they did systematic troponin on those patients. So there were 60 patients, mean age was 80, and 67% had positive troponin, none with an acute cardiovascular event. About 20 had a new diagnosis of CAD. What was interesting is that the rise of troponin correlates with the stress cardiomyopathy from a longer stay on the floor. So the longer they stay on the floor, the higher was the troponin basically. And there was this interesting scoping review, systematic review presented in one of the cardiology journal that basically says the troponin are probably very unuseful to do as a routine evaluation in elderly in the absence of acute coronary syndrome, because the geriatric syndrome can also increase a chronic value, and even age appear to be the most important factors related to elevated troponin. So second EBM take-home message: not order routine troponin on all simple fall patient. You really need to do good physical and an exam to make sure your correlates with your troponin. Very quickly for heart, make sure you do the orthostatic hypotension test, and 1 to 3 minutes is where you find the most significant findings. It's not useful to go over at 5 minutes. And just looking at brain evaluation, Dr. Goral talked about head injury. There's a couple of studies looking at fall, very dating early 2000. Do you need to do a CT scan? Probably only if you have a new physical neurologic findings. Odds ratio is 17 there. And if you just follow the following, it's going to reduce the routine head CT of those patients by about half if you don't have any neuro symptoms. There is no headache, new onset, no head injury, we just talked about, and there is no anticoagulation. Obviously, the anticoagulation part is going to probably evolve over the next couple of years. And similarly, there is an article that just came in about 220, an Italian big cohort looking at who needs to have a head CT in emergency department in non-trauma patient. So the one that don't have head injury but have a fall. So persistent neurologic deficit, new onset headache, altered mental state, and transient neurologic symptoms. So we're all going to same line here, is that you need to have something on your physical or your history to make sure that you prompt a head CT or troponin. So for take-home message, EBM wise, a complete history and physical, please do so. I know it's sometimes a busy environment, not easy to do. If you're unsure of cause, most people will say a simple CBC and bio-blood panel will be enough. Do not order routine troponin on all simple falls patient unless you really are worried about an event, a cardiac event, and do not order routine head CT on all simple fall unless your exam shows you something different with the patient, confusion or new neurologic symptoms. And now I'm happy to turn on the mic to Deborah Eagles in Ottawa.
All right. Thank you so much. I'm very excited to be here tonight to share with you some Canadian research around delirium screening. But I want to recognize Dr. Leanne Imond, who continue to do a lot of innovative work in this area as well. So as we're going through this talk, what I want you to think about is, what are you as a physician doing to assess for delirium in older adults? How often are you diagnosing delirium? And when is the last time that you wrote that a patient was delirious in their medical chart? So delirium has a profound impact on patients, families, and the healthcare system. It's extremely psychologically distressing for patients and families, and it is associated with significant morbidity, including increased hospitalization, ICU admission, prolonged length of stay, functional and cognitive decline leading to institutionalization and increased mortality. Not surprising, the cost to the healthcare system is staggering. And in fact, 10 years ago, it was estimated that the cost attributed to delirium was $164 billion annually in the US. But to give you a better understanding of the Canadian context, I'm going to share with you the results from a prospective observational study that was undertaken at both campuses of the Ottawa Hospital. The objective of the study was to determine the prevalence of delirium in ED patients 75 years of age and older. So existing studies reporting on prevalence are largely convenient samples and almost all require patient consent. But in this patient population, this likely leads to an underestimation of the prevalence, as delirious patients and those with advanced cognitive impairment who were at highest risk of delirium would be unable to consent and therefore excluded from these studies. So for our study, we received a waiver of patient consent from our local research ethics boards. We randomized 8-hour shifts at each site to include 24 hours a day and 7 days a week. An ED nurse trained in the use of the brief confusion assessment method, the Ottawa 3DY, and the Richmond Agitation and Sedation Scale assessed all patients 75 years of age presenting to the ED during each 8-hour shift. So we evaluated 355 older patients. They were a mean age of 83.6, and just overall, over half were female. 3/4 lived at home alone or with family, and 40% were identified as frail using the clinical frailty scale with a cutoff of greater than 4. In this cohort, 2/3 were discharged home. We found a prevalence of 14.6%. So of all patients that are 75 and older presenting to your ED, 1 in 7 is going to be delirious. So you may ask yourself, are ED care providers recognizing this common medical emergency? And to answer this question, let's take a look at a study completed by Dr. Iman and colleagues. They conducted a multi-center prospective cohort study in 5 Quebec EDs. This pre-planned sub-study wished to describe the proportion of unrecognized incident delirium in the ED. They enrolled consecutive samples of adults 65 years and older who had been in the ED for a minimum of 8 hours and required hospital admission. Research assistants were trained to assess patients with a confusion assessment method to determine if the patient had delirium. Recognition of delirium by other healthcare providers was determined by a review of all medical notes for the following keywords: delirium, delirious, confusion, or acute confusion. In this study, 65 patients were included. And what they found is quite shocking, in fact. Delirium was not recognized in 84.6% of patients. And it was missed by nurses, by ED physicians, and by admitting consultants. They concluded that delirium recognition rates remain unacceptably low despite a decade of efforts to improve this. And they stated implementation of new protocols to identify delirium are urgently needed in clinical practice in order for underlying causes to be identified and treated, and for patients to receive appropriate post-ED follow-up and care after their delirium episode. So how do we go about implementing a delirium screening protocol? Established methodologies and implementation science, including the knowledge to action framework, provided the basis for our strategy to implement a nursing ED delirium screening protocol at the Ottawa Hospital. There are many factors that play a role in successful implementation, but one of the most important is the identification of barriers and facilitators to behavior change. And an in-depth knowledge of these factors can direct specific interventions to address identified barriers, thereby enhancing uptake of the desired behavior, in this case, being screening for delirium. So we undertook a qualitative study using the theoretical domains framework. It is a set of theoretical constructs designed to identify determinants of behavior change that could impact implementation of evidence-based medicine. It's a well-established systematic approach with strong validity that allows for robust analysis of rich qualitative data. The TDF posits that factors influencing health professional behaviors can be mapped to each of the 14 domains that you see listed, and that each domain represents a potential mediator of behavior change. An interview guide based on the TDF was developed using an iterative process. The interview guide was then piloted. In-person interviews were conducted by our research assistant. The interviews were audio taped, transcribed verbatim, and imported into a software program for qualitative analysis. We used direct content analysis to complete the analysis using 14 domains of the TDF as our coding framework. A coding scheme, including definitions and example quotes, was developed by consensus through team discussion and updated iteratively during data analysis. So we conducted a total of 15 interviews until we reached data saturation. 717 utterances were analyzed and 77 belief statements were generated. They were grouped into the following three major themes: clinical prioritization, discordance between perceived capabilities and knowledge, and hospital culture. I'm going to dive a little into each now. So repeatedly, nurses expressed the importance of screening and early identification of delirium in older ED adults. However, despite recognizing the benefits of delirium identification and the consequences of missed delirium diagnosis for patients, half of the participants reported that delirium screening was not high when caring for older ED patients. They stated that their priority was making sure that everyone in the ED was stable. And they identified competing demands, lack of time, demanding workload as the greatest barriers to clinical prioritization of delirium screening. We found that regardless of geriatrics training or self-reported knowledge and confidence regarding delirium, none of the nurses in our study were able to accurately answer questions relating to delirium diagnostic criteria, types of delirium, or screening tools. Furthermore, they did not have the insight into this knowledge gap and expressed a false sense of confidence, with many reporting that they could recognize delirium using clinical judgment alone. Hospital culture and social influence played a large role in nurses' decision to perform a delirium screen. They noted that because delirium screening was not a formalized expectation for them, it was not frequently asked for by physicians or discussed in handover between nurses, that this led them to not often assess for delirium formally. On the upside, they did state, however, that they would be open to screening if there was an easier availability of a delirium screening tool, there was education and support from their nursing colleagues, and if they perceived that a positive screen changed patient management. So targeted interventions must address these barriers, and facilitators must be enhanced to increase the likelihood of successful adoption of a delirium screening protocol. So I've briefly highlighted that delirium is a common yet under-recognized medical emergency in older adults presenting to the ED. I've shared with you some of the results of the qualitative study that we conducted to identify barriers and facilitators to delirium screening. But if there's one thing that I would really like you to take away from this talk, it is to seek out the diagnosis of delirium. Don't expect the patient to say to you, oh, by the way, in addition to my nausea, I'm also delirious, because it's not going to happen. We routinely evaluate for evidence of renal failure and heart failure, et cetera, through our history, physical exam, and investigations. And we must take the same systematic approach with delirium, use validated tools to diagnose and document it in the medical record. And only then will we begin to see changes towards improved patient care and outcomes. Thank you. So with this, I'm going to turn the floor over to Dr. Jacques Lee.
Alrighty, there we go. Wow, how do I follow that? That was great. Let me do my best here. Let me share the old screeny. Yeah, that's the one. How's everybody doing up there? Hope you're staying warm and safe. Okay, here we go. All right, page up. All right, so I am going to tell you something much less useful than everything you've heard. I'm going to share the results from the emergency department ultrasound guided regional anesthesia to prevent incident delirium, the EduRapid trial. Safe and effective, but does regional anesthesia reduce delirium in patients with hip fractures? I am supported gratefully by the Schwartz-Reisman Emergency Medicine Institute, and I have a ton of coworkers, collaborators that I need to acknowledge. Thank you, everybody. All right. My objectives are to really review whether regional anesthesia is safe and effective, how long it takes to work, and its impact on delirium. So we got the idea for this study from a meta-analysis showing that delirium as a secondary outcome in 6 trials, there's some grade 2 evidence that giving the hip blocks might actually lower the incidence of delirium, right? And in preparation for our study, we did some KT work and surveys that showed that perceived time to perform the block and a lack of training were the 2 biggest barriers to adopting POCUS GRA for hip fractures, okay? So now we don't want to advance. All right. So the objectives of our study are exactly the same as your learning objectives, to see if it's safe, efficacious, and how long it took to perform. Our participants in the study included physicians who had to work at least 4 shifts a month, sort of a 0.25 shift line. And we excluded anybody who was not regularly doing, anybody who was already regularly doing POCUS GRA. Patient inclusion criteria included an age of 65 or greater. People had to need surgical treatment. We excluded patients with severe dementia and no substitute decision maker. So our intervention was a knowledge to practice intervention. So what we did to address the barrier of training is extensively develop, trial, reiterate a 2-hour training session that had 3 stations: a blue phantom station for finding the anatomy, practicing injecting, a chicken thigh model, which was really, actually it was a turkey thigh model. It was really helpful for practicing injection under fascial plane and doing landmarking without doing an injections on a live model. We also used reminder emails and coaching, and the results, the details of our intervention are available in the BMJ open paper that's referenced at the bottom of the slide. So how do you go about testing whether whether giving POCUS GRA can prevent delirium? We didn't feel it would be ethical to randomize patients to get a block or not get a block, because we already knew it was better for pain. So what we did is we took a large group, over 200 physicians across Canada, and we trained the physicians to do the block. Every patient seen by a physician before training was in the control group. We did it in groups of 4 to 6 at each center every 1 to 2 months. So what that does is patients treated by 1MD before the training are in a control group, and we compare those to patients who are treated after their training. And we use the validated confusion assessment method, CAM, as our main outcome measure. This is a graphic representation of a step wedge trial design, and that's why it's called a step wedge. So at the top, the first physician who isn't in the trial very long before they get training contributes a small number of control patients in light blue and a large number of intervention patients in dark blue, and so on. As you go down the randomization order, you contribute more and more control patients and less intervention patients, okay? So what did we find? We were very gratified that the vast majority of eligible physicians agreed to participate. And then, can you imagine scheduling 213 physicians across Canada to come to a 2-hour training session? It was no mean logistic feat, and I'm extremely grateful to my collaborators for doing that. And we were able to enroll 803 eligible patients. 287 were in the control before training, and 516 in the intervention. So of the 516 intervention patients, unfortunately, less than half actually received POCUS GRA. So after after you were trained, some physicians were really good and blocked nearly all their patients. Some physicians only blocked 1 or 2 patients, and on average, less than 50%. Those physicians who did perform the block felt comfortable, very comfortable, 72.8% of the time, and their perceived effectiveness of the block was greater than or equal to 6 on 10 in 60%. So how fast, how long does it take? It only takes 15 minutes. We have data from hundreds of blocks, from lots of physicians, learners, people with more experience, and 90% of blocks take less than 25 minutes. So if you think about your ankle reductions, your wrist reductions, there's a lot of procedures we do that take about the same time. Were they effective? Pretty much. Among those who received POCUS to your right, their starting pain average was 5 on 10, and they had a mean reduction of 3.2 on a 10-point numeric rating scale. 2/3 had a 50% reduction in their initial pain, and nearly 80% had a 30% reduction in their initial pain. Of our large group of patients, we only had 1 minor complication. That was a hematoma, and so that gives us a complication rate of 0.41%, with a 95% upper confidence interval of 2.24%. And again, only 1 minor complication. And remembering, these are physicians of all stripes, from participating emergency departments and experience. So what about delirium? You're the first people, you lucky people, anywhere in the world to see these results. We had a 19.3% delirium rate overall. Our trial did not show a statistically significant reduction in delirium between the 2 groups using an intention to treat group. There was 19.1% had delirium in the intervention group and 20.2% in the control group. And when we reanalyzed the data using a per protocol analysis, we also did not see a statistically significant difference. All right. So, despite the fact that this was a trial, people knew that we were watching, we were sending them reminders. The uptake of the block was poor, less than 50%. So I think that's a very, very important question that we have to ask ourselves as a community. Are we not able to do this? And do we need to ask somebody else to help us? Do we need to get anesthesia involved? Because really, that's not a great impact. I guess in terms of the delirium outcomes, one ray of hope was the fact that pain scores post-block were lower than in the group of patients with delirium, without delirium. Okay, so if we're looking here, of our 157 patients who developed delirium and the 646 who had no delirium, they had equal starting pain scores, but the pain scores in the patients who didn't get delirious were lower after the block. So in conclusion, POCUS GRA is safe and effective looking at a broad sample, pragmatic sample of ED physicians. It only takes 15 minutes, but we didn't find any evidence of improved delirium. But despite the lack of impact on delirium, I'm going to strongly advocate that we should be implementing this as a best practice just based on its analgesic effectiveness and ease of nursing. We're already collaborating with the Victoria group on such a quality improvement initiative. And my email, first name, last name, jacques.lee@Sinai Health, for anybody who is interested in doing so. I'm going to stop my share and I am going to turn it over to Dr. McRae. Thank you very much.
Well, thanks again to all the presenters for some fantastic lectures and some great learning points from all 4 of you. We have a fair number of questions that people have added to the chat. We also have 1 or 2 that have been emailed in previously. I'm going to start with a question for Dr. Graywall around antiplatelets as opposed to anticoagulants. So what about antiplatelet meds, and is there an increased risk of intracranial hemorrhage for patients on those medications that we need to worry about?
I think a lot of the traditional or like the older studies that have looked at antiplatelet agents have looked at like comparing Plavix or clopidogrel to warfarin. And so we tried to look at Plavix in the study that I had discussed, our population-based study. And so we looked at different antiplatelet agents. Unfortunately, with the like prasugrel and ticagrelor, there's too few patients on them to actually include them in our analysis and match on them. But we did match on patients on Plavix. So everyone was kind of matched on whether they were taking Plavix at baseline. The other thing with using administrative databases, over-the-counter use of medications, we can't really capture. So we weren't able to capture aspirin use. However, we accounted for a bunch of comorbidities where, you know, a lot of these antiplatelets would be used. And so we would hope that matching on those comorbidities, the medications that are using are appropriately matched as well. But another study that we need to do is compare antiplatelets to DOACs as well and look at the risk.
Thanks. A question came in via email for Dr. Lee, and is there a best practice for monitoring patients who get regional anesthesia for analgesia for their hip fractures? And is there any established recognition or treatment protocol for potential lidocaine or bupivacaine toxicity, or is it a concern?
Right. So whether it's a concern, obviously, if you think of it, it's a concern. So you can be worried about whatever you want to be worried about. We didn't find any last. We did have a protocol approved by our anesthesia colleagues, you know, and basically it's give them interlipid to mop it up, you know, if you get. But I think that the real important thing to do is to say here is, you know, when you're using ultrasound, right, like it's kind of hard to put it into the femoral artery or vein and not know it, right? So if you're injecting and, you know, you don't, the only way that would happen is if you don't have any idea where your needle is and you just start blindly injecting, right? So yeah, sure. Should I know how to treat a lidocaine or a bupivacaine toxicity? Sure, absolutely. Do I expect that we're likely going to find that? Well, we've provided evidence that, you know, if it occurs, it's less than, 0.4% of the time. And no, I don't think that, does that mean everybody should go on a cardiac monitor? You know, like, yeah, you can do whatever, you can do anything you want. It's risk benefits, but I think the benefits of the pain control and ease of nursing, if you did require every patient who got bupivacaine local, subcutaneously to go on a cardiac monitor, that means nobody's ever going to get this.
Great. Next question's probably best suited for Dr. Eagles and around the screening for delirium in the emergency department. So a lot of great work identifying barriers to screening for delirium. Based on what the informants told you in that study, can you suggest some ways of kind of systematic change in our emergency departments to help make delirium screening not just a priority, but more feasible on a patient by patient basis?
Yeah, thanks for that question. I think part of it is the choice of the tool that you use, ensuring that the tool that you're going to use is standardized across the hospital. I think also improves communication, improves that transfer between nurses. And the strongest the strongest thing that I got from the nurses was the feedback that they received actually from their colleagues. So it's getting that culture and having that accountability that when you talk about a patient, when you hand over to the next nurse that's taken over for fill in for your break, that is part of the handover, what their cognitive status is, which would include whether or not they were delirious, and using the correct terminology, not that they have some sort of baseline cognitive impairment that's part of it, but this is an acute delirium. I think it's really important to use that terminology because that conveys a certain amount of urgency and acuteness to the situation, which there is. Having champions absolutely is key. We're very lucky having nurse educators, having bedside champions, because the nurse educators are not there 24/7 in the ED. So there's lots of different things that came up with our qualitative study, which is why the qualitative study is so fabulous for getting this real wealth of information. And I'm happy to discuss more. So feel free to email me and I can talk about more things that we discovered. Thanks.
Great. And you touched on the importance of communicating when a patient has been identified to be delirious, and how important that is in the handoff between nurses and inpatient units. There was a question that is delirium the right term, or are we better off just simply saying altered mental status to convey a concern for a patient, or is there additive value to actually saying the patient's delirious with a capital D?
So I'm sure Dr. Leary-Imond could answer this question, but I think there's huge value, because altered mental status, yes, it does tell you that something is wrong, but there really is a difference between altered mental status from dementia, from delirium, from depression. So you can have many reasons for having that altered mental status. And so when you're talking about delirium, I think as I said, it causes you to go down a different path, a course of action. So when a patient is identified at delirium in our hospital, we have standard operating procedures that sort of the nurses will undertake, because they know what that means. And so when you don't use that terminology, then a lot of those other secondary actions don't occur as a result of it. So I think the terminology is really important. Yeah, Jacques, please add.
And of course, you've heard me say this before, I really like the analogy to acute brain failure. So like if we're treating a patient who's got pneumonia and congestive heart failure and renal failure, the fact that they have brain failure is really important, because it's just as significant to their outcome, right? It completely, to say that delirium is important is to say that patient agency is unimportant, because a patient can't tell you, hey, I'm having side effects from this medication, or I'm feeling better, right? So recognizing delirium as part of the holistic care of patients is critical, not just from a nicety point of view, but for providing good, informed medical care.
Another comment on the topic from Dr. Emil.
Yeah, very quickly. I think that, like Jacques said in his talk, preventing also incident delirium and talking about it is important. We've shown one previous study that it does cost about 4 days more of hospitalization on the ward, and with all the overcrowding we're discussing in the emerge, which is also a factor for delirium probably, then preventing that incident delirium is something we need to work on, just not finding the delirious, but preventing delirium.
Great points. Another question in the chat for Dr. Lee. Do you ever leave an indwelling catheter in for an ongoing infusion of local anesthetic?
That's really a question for like an Ian Chernoff or a Jordan Chenkin or a Mike Wu, right? Like I am not the ultrasound guy, right? I'm your average Joe. I struggle to learn how to do the procedure, and I can do the procedure and I get it, like 80% of the time, right? Leaving a catheter in has some potential advantages of duration, right? But with reducing times to OR, right? It may be less of a problem, and it also introduces issues around infection, right? Like if we do a single injection, the risk of infection is extremely low. Leaving catheters in a dirty area may be more. I think an unevidence-based speculation from my data is I think that my push is going to be to look on really making sure that the block was effective, right? Like really seeing that you got good pain control. I think that's more important, than putting in blocks. However, like I said, if we're only going to provide, we emergency physicians are only going to provide this procedure half the time. Yeah, maybe we need to get our anesthesia colleagues involved to, up the game, right? And yeah, sure. If every patient could get a catheter in the emergency department, that would be fantastic. I think we need to think about what's the best path forward. And I am goading my emerge colleagues out there. Do you want to lose control of this procedure? Do you want to cede it to somebody else? And I think if you don't like that idea, then we got to step up and do it.
Great. One of the points that we had in a chat internally amongst the presenters around the use of routine investigations, and this is probably a question for Dr. Raymond, but I think probably all the presenters could weigh in on this, is that, you know, in addition to the risk of false positive tests, we sometimes need to do things to be able to patients to be able to get them tested. So, for example, needing to use sedation for CT heads, and so there's an argument to be made that that routine testing of patients is not just low yield but potentially dangerous. So maybe you can just ask Marcel to elaborate on that.
Yeah, I mean, as an emergency physician, just doing a lot of nights, still doing a lot of nights at my age, having to sedate a patient to go for CT because, it was ordered by a previous colleague as a routine exam is sometimes very, it's a difficult and heartbreaking, to sedate a 95-year-old lady after a fall that may not have needed a CT initially. And similar for troponin testing, it's obviously there's a lot of false positive that will just create a kind of a following examination either by or test by cardiologists and so on, with the results of very unfrequent patient with either acute cardiovascular event.
Great. We're getting close to the end of our time, but we'll give Dr. Graywall a couple of questions. Whether it's a good idea to hold anticoagulation post-fall for patients with normal CT heads. And I guess on the other end of the spectrum, how do you approach starting anticoagulation or continuing anticoagulation in a patient at risk of falls?
So I think the big thing is, in terms of starting anticoagulation in patients who are at risk of falls, either the patient or like the patient's caregiver or whatnot needs to understand kind of the risks and benefits. So, are you treating a PE versus is it something for prophylaxis? And then what's their risk of bleeding? So having some kind of discussions about what your actual risk of bleed is going to be after a fall versus a head injury. And if the risks are outweighing the benefits, then possibly, having that conversation about maybe not starting the anticoagulant. However, if the benefits of anticoagulation are stronger than the actual risks, then it might be more appropriate to actually start the anticoagulation. For me, I haven't changed practice in terms of continuing anticoagulation after a fall. I know there's like the question about delayed bleeds and if they're still on the anticoagulant, are they at an increased risk of delayed bleeds? I think the incidence is so low of delayed bleeds. I warn patients about, you're on an anticoagulant, so something may happen and things to watch out for. So I think patients and families need to be educated, but I'm not necessarily holding the anticoagulation in these patients or keeping these patients for routine repeat imaging. I don't know if that differs between like my other colleagues here.
Great, thanks very much. And so with that, I think we're getting close to the end of our time that we have together. I wanted to thank all four of our brilliant presenters on your excellent work and for some great clinical pearls for care of older patients in the emergency department. I wanted to close with a public service announcement, again for CAEP's Emergency Medicine Advancement Fund, so that we can keep supporting young researchers and continue to build emergency medicine research capacity in Canada. So please donate if you're able. Thank you again to all four of our presenters. Thanks to CAEP for facilitating these rounds. And I hope you enjoyed your time with us tonight. Thank you, everybody. Wish you all a wonderful evening. Take care and stay safe. Good night.